First of all, I'd like to thank you guys for coming out on the last day of the conference and in the morning, and after you guys probably had a really good time at the baseball game last night, so thank you. I just wanted to share with you that we have over 1,500 tissue samples that we've collected from Wilms Tumor patients from 2018 to 2024. And 63% of those samples have been reported to have findings in a subset of this smaller group that we took, so like 955 samples. And these samples are collected from FFP and frozen tissue, and they are not just from nationwide. We actually get this throughout the United States and throughout the world. So this is a really large sample size. So when we got these samples and we've had like this large group, we're kind of interested in what can we see in these Wilms tumor samples. So we wanted to review the genomic profiles of the cases with the reportable findings, and moving forward, I'm going to call those the positive cases. We wanted to investigate the genomic profiles of the cases with no reportable findings, so those are going to be called our negative cases. And then we wanted to overall identify new significant findings that maybe can aid in diagnosis or prognosis. And I hope anyone in the room who actually does any Wilms tumor will actually go back after this talk or when you go back home and see if you actually see some of these common findings that we are finding in our Wilms tumor samples. So for those of you who don't know, Wilms tumor is the most common renal tumor with approximately about 500 cases per year in the US. It presents as an abdominal mass. It typically affects children ages 3 to 4, and it's usually unilateral. There's usually about a 5-year survival rate is about 90%. In 25% of the cases, the tumors can metastasize, and that's usually to the lung or the liver at the time of diagnosis. There are some predisposing syndromes, so there's ones that involve the WT1, so 11p13 region. And then there's also some other syndromes that give them a higher risk of developing Wilms tumor, like trisomy 18. But most of these cases are somatic in nature, and that's really what we're focusing on. So just to give you a little bit about some of the histology, so you can have favorable histology, and that usually shows this triphasic pattern of blastomal, epithelial, and stromal cells, which you can see on the figures. The epithelial cells are ones in the right-hand corner on the left picture, and then you can see the stromal cells are kind of in that center, and then the blastomal cells are kind of on the bottom right and also on the top left. You have unfavorable, which usually is aplasia, and this is found in about 6% of the Wilms tumor patients. Diffuse is worse than focal, so focal obviously is more defined. There's an association with TP53 variants for these types of cases. There's also the staging. So you have stage 1, which shows basically the tumor is confined to the kidney. Stage 2 kind of extends beyond the kidney. And then stage 3 infiltrates outside the kidney. Stage 4 kind of metastasizes to the other organs. And not on here is the stage 5 is when it's bilateral. There are known risk and prognostic indicators. So you have your very low risk Wilms tumor, which is your favorable histology. The tumor weighs approximately less than 550 grams. The patients are younger than 24 months, and they're treated with surgery alone. Your high risk have favorable histology. They're either at stage 1 or stage 2. They have loss of heterozygosity of 1p and 16q, and they are associated with more aggressive disease. You have some cases that have relapse, so 10 to 15%, and those usually have a loss of LOH on 11p15. There are cases that have anaplastic histology with a 1q gain and a 17 1p3 loss, or LOH, and that's basically an adverse prognosis since that contains a TP53 region on 17p, which we discussed in the last slide. So what have we learned from our cohort? So here is kind of a summary of showing you the 5 regions that we report out at Nationwide Children's Hospital. And for those of you who have not seen we do this by a microarray, and so the top row is basically your log2 ratio. The second row is going to be your allele frequency, and usually there's the B allele frequency, which I removed just so that way it fit on this page. The top row, which is the weighted log ratio, if you can kind of see the 0 line, that's going to be your copy number 2. Anything above is a gain, anything below is a loss. So you can see here in these bubbles are basically the number of cases we found, or that a number of times we found this in our cases. So you can see at 1P you do see a loss. You can see that in both of these plots, and then we saw that 141 times out of the 600 positive cases. The 1Q gain you see 296 times. The 11P we're seeing LOH, which you can see only from that second plot because the copy number is 2. And then you can see that there is a loss of 16Q, so 158 times, and then 17P at 68 times. And so, not surprisingly, the most common finding we found was that 11P15 loss, or LOH. So we found that in 391 samples, and it's at 65%. The least common finding is that 7P13 loss, or LOH, found in approximately 11% of samples. So just a reminder that 17P loss is usually associated with unfavorable histology and worse prognosis due to TP53. So besides looking at that one case where you see all the numbers of how many times we see it, the most common thing, we are only finding one event. So you see that we have 304 cases that only have one reported finding, and that is more than half the amount of cases. Then we have 168 that have 2 reporting findings. So for the co-occurrence findings, we saw that in 47 cases, we had the 1Q gain and the 11P15 loss, or LOH. And then for the next group of co-occurrence is actually where there's 3 findings, which is that 1P loss, that 11P again, and then adding the 1Q gain. So besides looking at the reportable findings, we also wanted to take a look at what's going on in those negative finding cases. So this is just looking at the negative cases only on the graph on the left-hand side. So what we were seeing was whole chromosome gains were present, which was also found in the positive finding samples, which is not presented in this figure. If you look, you can see the chromosome 12 is the most common gain that we found in the cohort. So this is about 261 samples that we looked at. And so that's about 13% that's found in that cohort. This is not the first time whole chromosome gains have been seen in Wilms tumor patients. However, most of the papers that were published in the early 90s, early 2000s and late 90s were really kind of a small sample size. And it is suggested that these are non-random common abnormalities. So this included the +6, the +8, the +12, the +18, and a structural isochromosome 7q. Besides seeing some of these whole chromosome gains, we were actually finding a gain on 2P that include the McN gene, and we observed that in 16 of our cases in the negative findings and 67 in the positive findings. And so this significance is unclear. However, it has been published that this might is important in Wilms tumor cases. So here's an example of isolated isochrome 7q. So when I started at Nationwide Children's Hospital, the first thing I was doing was microarrays, and I came across a case like this, which is completely negative for any of those 5 reportable findings, and I saw a 7P loss and 7Q gain. And so I was very intrigued by this, and I go, okay, this looks suggestive of an isochromosome 7q. And for people not in the room, if you never did microarrays before, obviously microarrays are only being able to show you gains and losses of the DNA content and loss of heterozygosity. We cannot tell structure, and obviously we can't tell anything that's balanced by a microarray. And if you look at this, the whole genome view here, you can see that you do see the loss and the gain, and it's clear in all 3 plots. Okay. We started going through all our cases, converting them from the genome version of HD19 to 38, and started actually using the database within the software, which was a huge overhaul and undertaking since we had so many cases. And so what I was able to do was kind of query the database and find out anything that had any chromosome 7, since I was really interested in this whole chromosome 7 situation in the Wilms tumor. So you can see that there are the plots, and the positive is on the top and the negative is on the bottom. You see that there's LOH gains, losses for each of those. And there are whole chromosome gains found in both the positive and negative samples, but you can see that there is an increased amount of gains of the 7q compared to the 7p. You also can see that there is an increase of the 7p loss compared to a 7q loss and the LOH. So I manually went and reviewed all these cases to see what they actually look like. And you can see that there, in blue is the negative cases and in red is the positive cases, that the gain of 7q and the loss of 7p, which is suggestive in ISO7Q, and it was present basically equally in both of these samples, so about 5%. We also found that there was a 7p LOH with a 7q gain, which may be suggestive of an ISO7Q. We also found that there was 7p gains only and 7p losses only, which is unclear. Oops, this is back. For those of you who are not cytogenetics, what does an ISO7Q look like? So at the bottom, you can see that there's 2 chromosomes. So the 2 sets of chromosomes. So the first is showing you the first chromosome in each set is your normal 7. The second chromosome is ISO7Q. So you have your P arm on top, your Q arm on the bottom. And you can see here that the second chromosome in each of those sets is missing that top arm, but is replaced with the bottom arm. So you can see that by the banding pattern that basically the bands kind of meet towards the centromere. So in summary, we obviously have known that 11p LOH is probably the most common finding in Wilms tumor, which is what we were also seeing. But there are multiple findings that are frequent events in these Wilms tumor patients. What we'd like to continue to do with this set is review any additional cases, since this was was part of the cohort, to see if there are any other important regions. We want to assess for any potential genes of interest, and then correlate histology and outcome for some of the cases that we actually do have data from, because as I mentioned, most of our cases are actually not within Nationwide Children's Hospital. And hopefully, the overall goal is that you can see that looking at a comprehensive genomic analysis can potentially help you to investigate and find new regions that might be of important and interest. Thank you.